I've been at Cleveland for about 25 years. My first research actually was with Ian Graham, and that's a lot longer than I think either of us want to think about, but Ian was a fantastic mentor, and it's a pleasure to be back and to be on a program with him. It's lovely to see you all. He has asked me to talk about something that he knows a lot more about than I do, which is really the guidelines, because he's been the chair of a lot of the guidelines for the European, on the European side. I'm going to talk a little bit about the US guidelines as well, and maybe show where they differ slightly from the European ones. But with that, let me just start and, I guess I use this. Oops. What did I do wrong?
Maybe I sort of made for No, go ahead.
Too much on there. So obesity we heard about is, you know, it's not just people eating too much or not exercising enough. It's a very complex and chronic disorder that we don't fully understand. And I'll just give you a little insight on that. There's a TV program in the United States called The Biggest Loser. Of course, Biggest Loser is the person over the course of a while who loses the most weight. And people lose, you know, we don't talk about stone in the United States. We talk about pounds. And these are people who lose a couple of 100 pounds. And they do it by exercising a huge amount and by going on a pretty strict diet. And they do great. They lose, you know, I mean, they look great. And, you know, then the biggest loser is the guy or the lady at the end of the season who's done best. Unfortunately, they've followed those people for about 5 years. And NIH, which is the National Institute of Health, has followed those people as part of a research study and shown that, unfortunately, all those people who lost all that weight inevitably put it on again. And what they've shown is that for those people to keep that weight off, they have to eat they have about 500 calories less that they would eat a day than the average person in order to maintain that. And for some reason, the brains or whatever in people with obesity are very good at holding on to calories and to weight. And when you try and fool the brain and say, stop doing that, it doesn't change the brain itself. So there's something complex in these people. And and there is a lot of prejudice against obesity everywhere. I think for all of us, we should think about that, you know, even people who work very hard at it, it's without a lot of support and help, it's very hard for them to keep their weight down. But obesity is a big risk factor for a lot of things, for heart disease and for diabetes. And I think you've seen this already. Ireland, at least for the proportion of the population over the age of 15 who are 30, who have a body, a BMI of 30 or above, Ireland is kind of in the middle here, somewhere in around here. The big winner is the United States, and we know this. There's, you know, the greater American male or female, you know, is something that we're very used to. So, you know, maybe we don't have a problem with bariatric stuff because we have to have those kind of beds and things for people anyway. All of our bathrooms are supported. You know, the bowls we have to have special because people are just pretty big, and they break. But diabetes is also a huge problem. And I think one of the things we haven't talked about is diabetes is a big genetic problem. And there are parts of the world where you would never think they should have a lot of diabetes because they don't eat that much. But like India, for instance, where diabetes is rife because it's very genetic. And certainly if you have a parent or a grandparent who's had diabetes, you're much more likely to have it. But diabetes, now there are about 415 million people with diabetes. By 2040, it's estimated that may go up to 642 million. We've already seen this in part about the United States. This is the change in obesity from 1994 to 2008. This doesn't actually move, but the proportions, the hotter colors are a greater proportion of obesity or diabetes. You can see it's really a radical change over a very short period of time. And this is a proportion of patients greater than 9% who have diabetes. And you can see it's the Southeast, Midwest, not as much in California, and Colorado is always the best. That's, you know, that's where the lean and presumably mean people are as well. We think the people in the Midwest are, you know, fat, but very nice. You know, they're very, very friendly. And this is just the tip of the iceberg. Kind of when different studies have looked at people who have cardiovascular disease who present with heart attacks or whatever, and we look to see how many of them have diabetes. Nearly 2/3 of them have some form of either pre-diabetes or early diabetes and are not aware of it. So it's really, you know, this truly is the tip of the iceberg that we're seeing. And what we do know is that diabetes is very bad for your cardiovascular system. There are a lot of reasons why that is, but one is that the blood fats, or which have a lot of sugar on them, tend to stick onto the walls of blood vessels more easily and block them. And that's sort of the genesis of heart disease, vascular disease in general. But one of the interesting things is that there are two types of blood vessels that can be blocked. There are the big blood vessels, which are in the heart and the head and to the legs, which we call macrovascular because they're big blood vessels. And then there are the small blood vessels in the eyes or to nerve endings or to the kidneys, which are much smaller. And we call those microvascular. And their response to how high the blood sugar is over a period of time is quite different. People who get macrovascular complications, often the macrovascular complications like coronary disease precedes the onset of diabetes, whereas microvascular complications tend to occur somewhat later. There's a pretty good correlation between keeping the blood sugar fairly low and reducing these complications, but unfortunately not so much for coronary disease. And in terms of trying to prevent coronary disease and heart problems, it's not just hitting at the blood sugar, that's not enough. We really have to hit at blood pressure, cholesterol, and other risk factors, especially smoking. So here's a kind of a sobering slide. It's kind of the iceberg slide again. If you're 40 and have diabetes and you're a man, you're likely to lose about 6 years compared to the rest of the population in terms of life. A little bit more if you're a woman, because women live longer. Most of that loss of life over that period is black, and this is cardiovascular disease. And so most people who have diabetes, they don't die of diabetes itself, they die of heart disease. And that's something that we now realize that once you have diabetes, you've kind of heart disease has already started up, and they're at high risk. And that's one of the things we're very aware of. And now, probably cardiologists like myself see almost as many diabetics as Jerry or Maeve, because these are my folks. You know, these are the people I see. I don't treat their diabetes as much, though there are some cardiologists that do. And one of the sad things about diabetes is that some of the drugs that we have, newer drugs which are really good for treating the blood sugar, when people have gone on them, they've had increase in actual cardiovascular mortality. So one of the things we have to take into account in people who have diabetes is not just their blood sugars, but what's going to happen over time in terms of their cardiovascular risk. And it's a really intriguing and interesting issue that we're learning more and more about. So what is prevention of cardiovascular disease? Well, cardiovascular disease is still, it's the #2 killer in the United States. Ian, is it still the leading killer in Ireland?
It still is, just about.
Just about. So
Cancer, yeah.
it's beginning to drop in the US, so cancer has just edged it out. There are more women than men die of cardiovascular disease. Kind of another thing that people forget, that women get cardiovascular disease later in life and often die from it more than men. And so it's not that women don't get it, they're protected a little bit for a few years, but they eventually will get it. And although we've seen there have been great changes in mortality in Finland, survival is still really down is still not what it should be because of cardiovascular disease in every country, including Finland and Ireland. And although we've gotten great in terms of blood pressure control, I think, or reasonably good, Ireland's actually pretty good, lipid control, smoking has really gone down. We've seen obesity and diabetes have gone up. And this, as we've seen in the middle-aged, middle-class population in the United States now, the mortality for whites has gone up for the first time ever. And some of this relates to diabetes, obesity, and a lot to, unfortunately, our opioid or narcotics epidemic, which is really affecting this population. So it's, Ivan showed some beautiful slides of, drops in mortality. It ain't continuing. We're going to have to really work it, and we really need everybody's help to do something about it. So prevention is really a coordinated set of actions at the population or individual level aimed at eradicating, eliminating, or minimizing cardiovascular disease and disability. And this is a key issue. 80% of cardiovascular disease, we're all going to die of something, there's no doubt about that. And that, at least up to now, is inevitable. We haven't done away with it, but a lot of cardiovascular disease is preventable, and so is a lot of cancer. So one of the things we're interested in is estimating risk, and we already heard about how we might estimate risk, and I'm not going to go into that, but we do know that people who have cardiovascular disease already, or diabetes, or renal impairment already are at very high risk, and we really need to work on their risk factors. And you saw this score already, which is useful. There are a number of other algorithms that you can use. None is perfect. We have probably all eventually have a fairly high risk of developing cardiovascular disease. In the next 10 years, it's what we're really interested in. If we think the risk is at 7.5% in the United States, 10% in Europe, if you have a risk of getting that in the next 10 years, then you're considered at very high risk. So we can do various things to try and affect the population, and Ivan is interested in the population. Ian has done fantastic work with the Irish Heart Foundation here to reduce risk in the Irish population at the population level, getting people more aware, getting them to do more things. Obviously, a lot of what I do and Maeve does is at the individual level, trying to counsel individuals to change their lifestyle. And that's not easy. It's a lot easier, though, after somebody has had an event. If somebody's had a heart attack, that's when you really get them. And, well, it's too late. I mean, that's when they already have, once somebody's had a heart attack, they're in trouble because they may have lost some heart function, and it's too late. And so we really want to get people early, and all of us can help each other in doing that. So the European guidelines say that the total risk estimation using a risk estimation system such as SCORE is recommended for anybody over the age of 40, even if they have no evidence of heart disease or any history of family heart disease. And the people who are at highest risk are those with diabetes, already who have coronary disease, and who have a lot of risk factors such as blood pressure, smoking, and high lipids. And the European guidelines suggest that the total cholesterol is okay, but what both American and US and European guidelines suggest is LDL cholesterol, which is the so-called bad cholesterol. It's the stuff that's most likely to stick to the blood vessels, and it's the one we really should measure when we're trying to decide whether somebody needs treatment. Triglycerides, which are fats that have sugar on them, are also important in increasing our risk of developing narrowings in blood vessels, but not quite as much as LDL, but we should still measure those. Very important in diabetes because they go up a lot in diabetes. And there are other moieties that we can use, but they're probably not quite as important as these two. And so if you're at European guidelines say if you're at very high risk, you already have coronary disease or you have diabetes, then an LDL goal of less than 1.8 millimoles per liter. I'm used to more the 70 milligrams per deciliter is what you should aim for. And there's greater evidence now that if you already have cardiovascular disease, if you can get your cholesterol really low, that you may actually slow the process down and in some instances get some very mild regression of the disease itself. But getting cholesterol down is important not just because it reduces the accretion or accumulation of lipids in the blood vessels, it also stabilizes them. And one of the things about heart disease is that we've learned is that inflammation is very important in this. So if you've got blood vessels that have blockages, they may remain pretty static for a long period of time. But for various reasons, they may act up and crack. And when they crack, the blood clotting cascade is started. And that blood clotting cascade causes blood clot to form on the blockage. And the blockage can go from a relatively mild one to a severe one virtually instantaneously and block off the blood vessel and cause a heart attack. So one of the misnomers I think that a lot of people have is that you need very narrowed blood vessels to have a heart attack. You don't. In fact, over 50% of the people who have a heart attack won't have a severe narrowing in their blood vessels. So preventive treatment of the atheroma with lipid lowering, particularly with statins, which are good at reducing the inflammation and irritation of the blood vessels, is important. And people who are at risk, an aspirin, which inhibits the coagulation cascade, is very important. They're the reason that that's important. So the guidelines talk to that. People at higher risk, 7.5% risk, you don't need to be quite as tough in terms of getting their cholesterol down. People who have low or moderate risk, getting their LDL cholesterol to a range of less than 3 millimoles per liter is what's recommended. And so in terms of what is the diet that you should avoid, trans fats, saturated fat, we've heard that already. Increase your dietary fiber, try and lose weight. All these will affect your LDL levels. For your triglycerides, body weight is very important. Losing weight, reducing carbohydrates is very important. No alcohol. If you've got high triglycerides, I'm sorry, may sing about, one drink a day being good, maybe even up to 2 if on a weekend. It doesn't work. If you've got high triglycerides, no alcohol because it really increases your triglyceride level. And this is genetic. It's kind of sad, I mean, it's bad luck. If you've got high triglycerides, you really probably shouldn't drink. And it's not that you've done anything bad in life. You just pick bad parents, So the physical activity is important in everything we do. And one other message we need to get out to our friends is activity is good. Keeping active at any age is really good. So for HDL is the cholesterol that, it's the so-called good cholesterol. It's a transport that brings the bad stuff back to the liver to be broken down. And we used to think that it was a positive risk factor. If you had a high HDL, then you were in better shape. The evidence isn't as clear now, and there's some kind of HDLs that are really high that the HDL isn't working very well. And we have a guy working in our place who's sort of the world expert on that. I used to take delight in the fact that although my LDL cholesterol was okay, it wasn't too bad, my HDL was quite high. Now I don't. I'm afraid can't relax in that anymore. I have to think of what my LDL is more than my HDL. But getting your HDL cholesterol up is probably helpful. Exercise, small amounts of alcohol can help, and a good, healthy diet is probably what would help. But there have been a couple of studies which have looked at increasing HDL cholesterol with drugs to see if that would impact the incidence of cardiovascular events. It didn't. So, HDL is a little off the boil at the moment. Still important, but not quite what it was. And so the things that we need to keep on top of in terms of foods we should try and eat are cereals, which are whole grain, vegetables, legumes, fruit, and keep away from sweets. Now, I'd be interested to hear what our endocrinologists say about using aspartame and other sweeteners, because there's sort of increasing evidence that even people who substitute full sugar drinks to diet drinks, that they don't get much of a reduction in weight and things like that, and that maybe the brain is kind of fooled by even the sweetener. But anyway, that's something that we can talk about maybe a little bit later. We should go for meats and fish, which are lean, poultry without skin. All the things we know our mom said were good for us, we should try and go for, and avoid frying and full cream. Though, nutritionists are a little bit, will say that the absorption of food is slowed down by fat. So, fats, a Mediterranean diet that's high in olive oil is probably good because it slows down the absorption. It doesn't, all of the sugar and other things doesn't get into our bloodstream quite as fast. And that leaves us more full and maybe easier to absorb. For central obesity, the definition in Europe is that for men should have a waistline of less than 94 centimeters. Women should be less than 80 centimeters. It varies by ethnicity, and I'm not going to talk about that, but their guidelines in Europe are they're very common sense. The kind of Ian type guidelines that use a lot of, they're common, they're smart. And so their dietary recommendations should take into account local food habits. A wide variety of foods should be eaten. Fruit, vegetables where possible. Foods rich in trans or saturated fat, such as hard margarines, fatty or processed meats, should be avoided and should be replaced with monosaturated fats, such as extra virgin olive oil and polyunsaturated fat. And salt intake should be reduced. As we heard, moderation in alcohol, except for high triglycerides, try and avoid it. Physical activity should be encouraged, aiming at least 30 minutes per day, and no tobacco. So in terms of drug treatment, if you are required to have drug treatment, then a statin is usually the first-line drug. If you can't tolerate a statin, ezetimibe or bile acid sequestrants, which block the absorption of cholesterol, are the next in line. And the European guidelines say you're very high risk if you have diabetes plus or minus one cardiovascular risk factor or target organ damage. High risk are all those others with diabetes. In the US, we kind of would say once you have diabetes and you're over the age of 40, you're at very high risk. So I'm not going to go through the lifestyle modification. We did talk about glycemic targets, and just to reiterate that for microvascular disease, keeping your hemoglobin A1C, which is the amount of hemoglobin that has sugar on it, and that should be normally around 5% or so. In diabetics, we look at it as a sort of it gives us a sense of how sugar control has been over a period. That should be less than, ideally should be less than 7%, even 6% would be even better. Certainly if you get the target to less than 7%, you slow the rate of microvascular disease. But like I said earlier, for macrovascular disease, like coronary disease, that relationship isn't as clear. Certainly getting the blood sugar low is probably helpful, where it's not enough. And so you really have to look at other things. You have to get cholesterol and blood pressure down. So finally, a few words on the American guidelines. Are very similar to the European guidelines. For once, the US and Europe agree on most things. The US guidelines would say that there are 4 groups who will benefit from statins: people who already have coronary disease, people who have very high elevations in their cholesterol, can divide cholesterol by about 38 to get the European numbers. Individuals who have diabetes and are 40 to 75 years of age without obvious coronary disease will benefit, and individuals without clinical coronary disease or diabetes who have a high 10-year risk of 7.5% or more, who are likely to develop coronary disease of about 7.5% over the next 10 years, those should go on a statin. And again, the guidelines in the US are a bit more specific, getting the blood pressure down to less than 140/90, and that if you're treating blood pressure in diabetes, you should try and include an ACE inhibitor or an angiotensin receptor blocker, because they protect the kidneys more in diabetes, and similarly in chronic kidney disease. And for people who are brittle diabetics, who get their blood sugar goes too low, we can be more tolerant of hemoglobin A1C, which is a little outside the usual range of 7%. We need to, hypoglycemia is not good for people with cardiovascular disease because they tend to have more events with it. So I would say these are the biggest guidelines from the US. Recommend aspirin, but I'm just going to finish up about overweight and obese patients. Should be counseled that lifestyle changes can produce a 3 to 5% reduction in weight loss. So instead of, and this is where I do with my patients, instead of saying, look, you need to lose 100 pounds, which is overwhelming for people, I say to them, try and lose 10 pounds, 20 pounds, and keep it down. Is going to have a much bigger chance of improving your health and make you feel better about yourself than sort of saying, I'm going to try something that's not manageable. But the American guidelines say that if you have a BMI of greater than 40, or you have, or over 35 with a comorbidity, and you haven't responded well to treatment with diet or with pharmacological treatment, then bariatric surgery may improve your health. And that's a class 2A guideline. Not everybody would agree with that, but it's an awful lot different than the guidelines we had a couple of years ago. So bariatric surgery, as Maeve said, is really in. It's really in for the treatment of diabetes. Our Cleveland Clinic did one of the big studies of bariatric surgery in pre-diabetic and diabetic patients, and called the Stampede study. We were all a little cynical about it initially. I mean, I didn't think it was going to work. I thought, this is ridiculous, it'll never work. And over 5 years of follow-up now, the prevalence of diabetes I mean, not that people don't get diabetes, but their diabetes is so much easier to manage, and they're not on, a huge cocktail of drugs to manage it. So I think bariatric surgery is important. It's here to stay. I actually recommend it for quite a few of my patients. I've had some great success stories with it. And, the best chance of people losing weight is in the first year. They can lose an awful lot in the first year, and if they do, they tend to keep that down. But, you know, it doesn't mean that they can do everything they like. And I also see a lot of people who put on a lot of weight after bariatric surgery, and you know, they may not get quite up to where they were before, but it's not always that successful. Our biggest problem in the US is insurance. None of the major insurers will pay for bariatric surgery. They'll pay for all the drugs, they'll pay for, you know, all these other things, but they won't pay for bariatric surgery. It's very hard to get them to do so. So people have to pay for it themselves out of pocket, and that's one of our biggest struggles with it. Anyway, I'm going to stop there, and thanks very much.